It is now my pleasure to introduce our keynote speaker, Dr. Seema Yasmin from Stanford University. Dr. Yasmin's background makes her uniquely qualified to talk about the issues confronting medicine today. She is a physician trained at the University of Cambridge in the UK, who has worked as an epidemiologist studying emerging infectious diseases at the US Centers for Disease Control and Prevention. Realizing that effective communication was a major tool against epidemic infectious diseases, she completed a journalism fellowship at the University of Toronto. I became familiar with Dr. Yasmin when she came to Dallas, Texas to be a member of the faculty at the University of Texas at Dallas and simultaneously served as a reporter for the Dallas Morning News. I was astounded by her articles in our daily paper that brought important public health problems to view in plain language aimed at the community, not just public health scientists. Her work was nominated for the Pulitzer Prize and received an Emmy Award. Dr. Yasmin is currently Assistant Professor of Medicine at Stanford in Primary Care and Population Health. She is the Director of the Stanford Health Communication Initiative. Her work has appeared in the New York Times, Wired Magazine, Scientific American, and Rolling Stone. She is the author of 4 books, including her latest, Viral BS, Medical Myths and Why We Fall for Them. Today, Dr. Yasmin and I thought we would try something different, a keynote in the form of a conversation, and I hope you enjoy it. Hello, Seema. Thank you for kicking off ACR's Convergence. Before we jump into the discussion of COVIDization, why don't you share a little about your journey?
Sure. So a little bit of an unusual journey in that I come from a family in the UK where it wasn't typical for people to go into medicine, but my family background, and that's an immigrant South Asian family, Muslim, arrived in England in the 60s and 70s, has really colored the way that I think about medicine and practice medicine, and also the way that I think about journalism and information sharing. I wanted to be a doctor when I was younger, but I had school teachers tell me that people like me don't get into medical school, and so I shouldn't bother applying, and so I didn't, thinking that was the right advice. In England, of course, you can go to med school straight out of high school, but I did it the kind of American way. Did my undergrad, had mentors that believed in me, and then went to med school in a very elitist bubble. And as soon as I graduated, I knew I wanted to get out and practice in the real world in my backyard, so I went back to East London. That was the point where I realized I love clinical care, but I'm a public health doctor at heart because I was always interested in the root causes of illness and looking at trends as to where people were getting sick, when, and why. And that's what led me about 10 years ago from leaving hospital medicine to arriving from England in the US to serve as an officer in the Epidemic Intelligence Service at the CDC. And I loved that job because it was very exciting, dealing with different contagions in different parts of the world. But it was during that experience as an EIS officer that I realized in the public health world, we weren't often thinking enough about how we communicated with the public, and that they were our patient population. And I was seeing, David, that no matter where I was sent, no matter what contagion I was deployed to stop, it was never just a pathogen that was spreading. There were all these rumors, health hoaxes, and medical myths, so much misinformation and disinformation spreading alongside an epidemic, really fueling the epidemic. And yet we in the public health world were so singularly focused on a pathogen and not people's beliefs about public health, about the work that we did, people's beliefs about vaccines. And at that point I thought, if I'm going to be effective as a public health doctor, I think I need to get trained in communication. And the only way I really knew to do that was to go to journalism school. So I did a journalism fellowship at the University of Toronto, not knowing what I would do with that qualification, but knowing that in some way it was going to be an important skill. And then, of course, as you know, I ended up in Dallas being a reporter for the Dallas Morning News. To kind of bring it full circle, I now work at Stanford, where we're really studying the information ecosystem. How does misinformation about vaccines or masks or science in general, how does that misinformation and disinformation spread? So for me, what I've tried to do with my career and continue to do is connect those dots between the people who we are supposed to serve, people like my family who are not in the medical field, but whose health we really care about deeply and who often get sidelined when it comes to communication about health and science.
Yes, my first introduction to your work was when you were writing for the Dallas Morning News. And I have to say I was a little bit taken aback because it's not typical for the Dallas Morning News, which is a rather diverse newspaper, to have someone with your background reporting directly to the public. And I thought this is very refreshing because we're hearing a very different view, and we're hearing someone with a scientific background, a medical background, speaking directly to the public in a way that I think the public could better understand. And I'll come back to that in a few minutes, but I just want to say it was very refreshing, and I was very sad to see you leave. Now, you've talked extensively about this panic neglect cycle in epidemics and how you teach crisis management to MBA students, where you explore how and why humans panic during a crisis, then neglect to plan for future crises. You know, given our response to previous pandemics, like the H1N1 pandemic, or where we depleted the national stockpile of PPE and N95 respirators and then failed to replenish that supply, do you think that medicine will return to business as usual after this pandemic? Is it even possible to maintain our previous status quo?
I don't want us to go back to what was the status quo. And I used to get asked this question, phrased differently though, in the beginning of the pandemic. I'd say in the first 9 months, David, a question I'd get asked all the time on CNN or whatever platform: when will things go back to normal, Dr. Yasmin? And I think, do we want it to go back to normal? Wasn't normal the set of conditions and circumstances that led to this crisis? So for example, when we do exit this pandemic, when this new coronavirus becomes endemic, say, if we sigh a massive sigh of relief and go back to business as usual, we will have failed, because the climate crisis is still here. We still have supply chain issues, which we can talk about. We still have an epidemic of burnout and moral injury amongst healthcare workers that predates the pandemic. So the status quo wasn't great for the majority. Maybe it served the needs of a minority, but I don't want to go back to that normal. I really hope. And you mentioned I teach crisis management. I teach that at the UCLA Anderson School of Management. And one of the things I teach my students early on, because I'm really into words, as you know, is the etymology of the word crisis. And my understanding is that it comes to the English from the Greek, where it has a bit of a medical origin. And actually, crisis, spelled with a K, referred to the point in a patient's illness when they might rapidly deteriorate or fully recover. And so crisis was really used as a term to refer to an inflection point, a pivot point. Things could go really wrong, but they might also get better. Of course, at this point, we have descended into crisis upon crisis upon crisis with the pandemic, but we've seen so many of those inflection points at which we could have seen a different course. We could have seen containment, for example. We could have seen much better deployment of PPE. And we failed over and over again. And so I don't want to go back to a normal that is the preconditions for another crisis. I want us to create a new normal where we are more resilient and less vulnerable to pandemics like this one.
So I think great minds think alike. The theme of my presidential address was, you know, we don't want to go back to normal.
Yeah.
So maybe you could expound a little bit about that. What are the specific things that you think are going to be, and I hesitate to use the term new normal, but the new better?
Yeah, the new better normal. So what I hope that looks like is systems that are designed to be more resilient, systems where we're not relying on a crisis to come along and shine a light on all that's broken. I think some of the things that are foundational in medicine need to change, and that calls for a paradigm shift that can feel very revolutionary, but we're dealing with things like suicide amongst our colleagues. I don't think that's new to many of us. It's a problem that's predated the pandemic, and one that the pandemic has brought to light. And if it's not suicide, it's other mental health issues. It's people feeling like they can't continue. It's attrition. It's less optimal patient care because of that. So that's just one area in which I hope we see a radical shift in terms of how we talk about those issues, how we care for one another. I think so many of us at this point have even heard those awful stories of a resident saying they are in crisis and an attending saying, well, you better go get your mental health care out of network or out of county because it's going to impact your fellowship. I mean, things like that to me are a crisis, and they feed into these bigger public health crises and make us less optimally placed to deal and get out of a crisis.
So given how the past 20 months have impacted our practice of medicine in a deleterious way, what are some things that we could be thinking about doing now to prepare again, I hesitate to say when the pandemic is over because I'm not going to predict that time period. But when that happens, what are some of the things that we can be thinking about now to prepare for the future?
Yeah, so I think there are basic things that epidemiologists talk about, like better surveillance systems, transparency and better communication between different countries or different agencies within countries, and then those more resilient workforces and more resilient systems that I mentioned. But also, something that this pandemic has so painfully revealed is the lack of scientific literacy among the public. So going back to the public, something we've had to do is get people up to speed on rapidly evolving science as we're learning it, right? We're building the bridge as we cross it. And we're sharing that information with the public and realizing it's not hitting home. We're not communicating it well. Like one example is early in the pandemic when Dr. Fauci was saying, well, we don't think you need to wear a mask. And then a few weeks later, Dr. Fauci saying, actually, we're going to recommend that you do, but don't go buy them off and take them off the shelves. We need them for healthcare workers. Maybe sew a cloth mask at home. To a scientist, that reads as, oh, that's good science. That's someone changing a recommendation based on their assessment of the best available data. That's how you do science. To many in the public, that read as flip-flopping, as ambivalence, as these leaders don't know what they're doing. Do scientists even know what's going on? And that shows how difficult it is in a crisis to get the public up to speed when you haven't had investment in education. So I think so many of these things are not quick fixes that we want to hear about, but they are paradigm shifts and they are generational issues that will take time to fix.
Now, in a lot of your written work, particularly your most recent book, you talk about myth busting and how healthcare and society needs to be trying to dispel these myths. How really can healthcare workers address this? We're not trained in medical school to be myth busters and to take on these conspiracy theories and issues about vaccines, etc. How can we better educate ourselves to do what you're trying to do through your writing?
So yes, I write about myth busting and I study that, how we can develop better interventions. But as I wrote that book with different myths that I was dissecting, whether it's like, should you eat placenta pills? No, you should not. All these different health myths that are circulating, I thought, I think I'm going to have to write an introductory chapter that is a confession about the myths that I used to believe, because really that upbringing, the family background that I talked about, has led me to where I am now and led me to have a lot of empathy and understanding for why somebody might believe something that another person is like, that's absurd. How would you think that a government would microchip its population through vaccines? And what I say in that introductory chapter of Viral BS is that I grew up believing a ton of conspiracy theories, and that's because my family and my community did. So we have this focus on the science, what's inside the vial, and not everything around it that leads someone to say, I trust the government, no I don't, I have legitimate reasons, or I've heard these other things. We're not addressing any of that, and we're not trained to, and I really want us to change that.
Well, I think some of us are trying. Just yesterday, I had 6 medical students working with me, and we were talking about cultural differences and how to talk to patients who may come from different cultural backgrounds. But I'm afraid that we're, one 90-minute session with a faculty member in the first year of medical school is just not going to cut it. We need to sort of hit on this over and over again, and not just talk about people's religious backgrounds or the country their grandparents came from, but some of these cognitive biases. How to get past thinking that is not quite right. Now, in a moment of deja vu, I'd like to take you back to February of 2015, and this was when you were here in Dallas. And on the front page of the Dallas Morning News was an article about the fact that more and more Texas parents were opting not to vaccinate their children against measles, citing that now discredited Wakefield article in The Lancet. And in your accompanying opinion piece, you wrote that when you joined the CDC, you expected to battle rare diseases and instead fought outbreaks of the ones that we had already conquered. You mentioned that most millennials had not seen the horrors of uncontrolled measles or whooping cough or other preventable infections. And you said, we may have to relearn the horrors of these diseases before we rid them, I think. And it seems that our current COVID vaccine hesitancy is just an old play with a new actor. Totally. And so why are vaccines, always an issue for some people?
Yeah, so there are talks I give about this where I set the scene for the audience and I say there's this group of people, they're in a town hall in San Francisco and they are organizing against a vaccine mandate. They are organizing against the use of masks as mandated by the local government. And then I say, and by the way, this is the Anti-Mask League of 1919 that I'm telling you about. Like, these are not new phenomena. And so much of it goes back to this issue of us not understanding in the first place why it is that somebody might be vehemently opposed to a small piece of cloth that makes a mask, or to the incredible science that goes into a vaccine. And we've been negligent in our understanding. If you talk to 6 different people, or you look at the studies that analyze people's beliefs around vaccines specifically, 6 people who are saying, I don't want the COVID shot, may have 6 really different reasons. One of them might get her flu shot every year and have her kids completely up to date on their childhood vaccines, but really be on the fence about the COVID vaccine because of how quickly it went through the regulatory process, how quickly it was developed. Someone else might have much more opposition to vaccines in general. Without eliciting how they got to that belief and just focusing on, like I said, what's in the vial, we're using a one-size-fits-all message for everyone, even though we're coming to our decision about whether to get the shot or not from really different places. And ever since I was at the Dallas Morning News, and I continue to do this now, I've been tracking the spread of specifically anti-vaccine messaging across social media sites and also talking to people on the ground. And it did used to be mostly those kind of Wakefield-driven vaccines cause autism kind of messaging. Increasingly, what I'm seeing and what other scholars are seeing is this messaging that says vaccines go against the American way of life. If you get vaccinated, you are anti-freedom and anti-American. So we're up against these really polarizing ideologies that we're not dealing with. So for me, any question about vaccines is about everything that goes into making a vaccine. It's about someone's belief about science, their understanding about the scientific process. It's about how they feel about government and the medical establishment. And I remember thinking in 2020, when we were getting the data from the RCTs for the vaccine clinical trials, like, this is amazing. We've never done this so quickly before. Why haven't we managed this before? Why have we managed it with malaria? All those questions. But at the same time, I was thinking the very thing that was making us excited, like the speed of scientific process, was the same thing that for many in my family, my friendship circles, people were saying, they're doing this so fast, how can it be safe? So while we're in the lab developing the therapeutics, developing the vaccines, concurrently, we should really be out there studying what people think about this process, what they understand about it, and also at the same time developing targeted messaging for different communities. And we didn't do that. So we come out with these incredible historic vaccines, and then people refusing to take them for a myriad of reasons, us not truly understanding why that is, and not having really done the work or the preparation to say, let's explain to you in a way that you understand why we were able to do this so quickly. And by the way, we understand that your particular community has a legitimate reason to not trust the federal government, to not trust the CDC. Let's talk about that history, let's atone, and let's build bridges.
I think there's been vaccine hesitancy ever since Edward Jenner, inoculated his son with cowpox. But, in the United States and the world in general, we've had 100 years of modern vaccinology, and this vaccine hesitancy keeps coming up. It just seems that we should be better prepared as physicians, as healthcare providers, to address this head-on, to anticipate this. And I don't know why we didn't. I think, as you say, we in the science world, in the healthcare world, thought that these vaccines were great. We knew that the mRNA technology had been around for 20 years and was developed for SARS itself and was just waiting for the next pathogen. So we know how great this was, but the public had forgotten what pandemics or what even epidemics were like. And,
oh, sure.
You know, in people of my generation, when I was a child, you know, the polio vaccines came out and our parents took us to a vaccine site and we all either rolled up our sleeves or took the sugar cube with the vaccine on it. And we all thought it was great because we could remember the pictures of rooms and rooms of children in iron lungs or children with braces or even Franklin Delano Roosevelt. But we really need to, I guess, you know, have those images in our head in order to get serious. But I don't know why the images of people prone in ICUs on ventilators, you know, really didn't get people interested in taking vaccines.
Because I think when there's such intense polarization, there are even studies showing that when there are parents who are either on the fence or opposed to vaccines, showing them photos of a baby in the NICU on a ventilator because of pertussis, for example, can actually push some people further towards the I am not getting my kid vaccinated camp. So we really need to understand on subpopulation levels how people come to those beliefs. But absolutely, these are long-standing issues that, yes, are to do with the vaccine, but also to do with trust in government, trust and understanding in the scientific process. And I think one of the answers to your question is hubris. I think we've been so prideful, like, hey, but here's the technology, it saves lives. If we're not connecting with the public about what that means, how it was developed, as the process goes on and on, so going back to scientific literacy, then this is how we end up in a situation where I came to the States 10 years ago thinking, as you mentioned, oh, novel emerging pathogens, I'm going to get sent to these outbreaks, but no one knows what's killing everyone. And sometimes it was that, but the bane of my life when I was in the Epidemic Intelligence Service was whooping cough. And in med school, I remember a professor playing as a cassette tape, so we would know what the characteristic whoop of whooping cough sounded like because we weren't going to see it on the wards. And how we understood what the rash of measles looked like, or Koplik spots, was from textbooks. It was really, they looked really old and dated photographs, right? And perhaps we were being taught this because, well, you know, these things are emerging, but we weren't seeing it, or we might go to work in low-income, resource-poor settings where we need to, you know, recognize this pathology. But then I arrive in the States, and one of my first outbreaks is an outbreak of whooping cough in a NICU in Arizona, and it was because the healthcare workers weren't vaccinated, had whooping cough, went to work and coughed on the babies, the preemies, in the NICU. And it goes back to policy. Personal time off was lumped together with sick leave, so there was an incentive to continue working through a hacking cough, never mind that the babies nearly died. And so that blew my mind. And not to say that it was only happening in the States. We're seeing the reemergence of vaccine-preventable diseases for sure in Europe and all around the world. But there is a generation of us that don't know what whooping cough sounds like, are only just starting to recognize it and starting to see it. But I feel like there's this massive disconnect between public health, between the medical establishment and the people we are supposed to serve.
I agree. I'd like to switch away from vaccines for a bit here and come back to something you talked about. You mentioned two things. You mentioned resilience and burnout, and you mentioned supply chain, which I hadn't thought we would talk about. But those really are becoming issues that we're seeing throughout our lives. There's no used cars to be bought these days. There's no Apple iPhones, I heard, are in short supply. But how is this going to impact us in medicine? So if you want to tackle maybe supply chain first and then talk more about resilience.
It's been an issue. In fact, one of the stories, and I always had so many story ideas I never got around to, but one of the stories I wanted to write when I was a reporter at the Dallas Morning News was, how can there be a shortage of IV saline in America? How can, like, really basic medicine, sometimes I'd get these alerts from these public health surveillance networks about a shortage of a pretty, what I would think of as a ubiquitous drug. And I really didn't understand that, but these are huge vulnerabilities. Right now, you talk about the car issue, going back to microchips and a lack of preparation back in 2020 when we were seeing a massive decline in shopping. And now we're seeing the Port of Los Angeles, for example, is going to operate 24/7 because there's a resurgence in online shopping or just shopping in general. We're seeing this in the UK around petrol too. And these are complicated issues when it comes to supply chains, but it goes back to things like Brexit. So politics, and it goes back to the pandemic, and it goes back to immigration. All these issues which are so interconnected, which we sometimes think of in very isolated or siloed ways. And that's where I think the lack of resilience comes in. So I think in envisioning a future in which we are less susceptible to pandemics, or at least less susceptible to public health crises of this scale, we're going to have to see medicine sitting at the table with other industries, thinking about ways in which we are all connected and how do we develop that resilience together. And then I guess it's similar on a micro level in terms of thinking about resilience, mental health, and the workforce. And I keep coming back to this because it's just at the top of my mind in terms of friends as well who ended up deploying around the country to help in overwhelmed ICUs from Arizona to New York to LA. How do we care for those people who have invested so many years of training to be expert providers and with whom we're seeing attrition because we're not taking care of them? That is not building towards resilience. That's a really, really broken system.
I think, in rheumatology, if I were to talk about the supply chain problems, it's last year in 2020, we saw a shortage of hydroxychloroquine for our patients with lupus and rheumatoid arthritis. And that was due to, unfortunately, a false narrative that the drug would be useful for treating patients with COVID-19. And then this year, we're seeing shortages of a drug, tocilizumab, that actually does have some benefit in treating severe COVID-19. But the companies that make these drugs haven't ramped up their production or didn't anticipate, even when the studies came out last year, didn't anticipate perhaps the Delta surge being a big strain on the system. And then, the supply chain isn't just the manufacturer shipping directly to the patient. There's a lot of places in between where hoarding can occur and other activities that limit supply to our patients. I don't know how we can fix that and sort of be future-proof for all of these emergencies.
I mean, I think there are ways to think about supply chains in terms of crisis management and preparedness. There's an art and a science to thinking about that. And it's not to say that you can prepare for every eventuality, but you can make sure the strategic national stockpile is replenished once it's depleted from one pandemic 10 years earlier. Again, to me, some of that comes back to hubris, like whether it's belief that because we live in an industrialized Western country, we won't be hit as hard, and whether we needed a crisis of this magnitude to demonstrate that we are really vulnerable, that an epidemic in one country is a public health threat all around the world. But I think a lot of it comes back to understanding our vulnerabilities and recognizing that we live in a world that is more and more susceptible to epidemics and public health crises. Actually, climate change, mass migration, all of these make us more vulnerable. Are we not being prepared? Are we just assuming that the next one won't be this bad? In many ways, as horribly tragic and disruptive as this has been, just looking at the virology, looking at some of the characteristics of this pathogen, it's actually not as transmissible and not as, CFR isn't as high as some of the worst case scenarios that, we think about. Something with an R0 somewhere closer to measles would be a nightmare. This wasn't even that. And look at the state that we're in.
Correct. I mean, I think that's perhaps why there was a lot of calm early on, because people looked at the R0 and said, oh, it's not measles, it's, and we can control it because we controlled SARS, we controlled MERS, we just need to keep control of the outbreak and it won't go anywhere, and didn't really understand what the virology was, and more importantly, the transmission, not just from person to person, but somebody traveling 1,000 miles on an airplane and going to a crowded room.
But you say like the lack of understanding about virology. Sure, it's a novel pathogen by definition. It's new, right? We don't understand everything about it. But why were we so behind in our understanding? Well, look to Baylor, look to the scientists in Houston who invested years and millions of dollars in studying SARS-CoV-1 and a vaccine. And then a few years after that epidemic, it was like, are the funders really that the funders are not that interested anymore. It seems like quite a distant memory, that epidemic. a half-baked vaccine is left in the deep freeze. Quickly thaw it, now we have SARS-CoV-2, or it looks like actually a pretty closely related cousin. How advanced might we have been in not just developing a vaccine for this novel coronavirus, but in our understanding of its transmission, in our understanding of its pathophysiology of the infection? And again, to me, that's hubris and a lack of preparedness. And you talk about the calm at the beginning of the pandemic. I don't think it was calm. I think it was really frantic, not knowing what to do, not understanding some of the geopolitical issues. Was China being transparent? Was it not? What were we learning from there besides what was being held back? So there were all of those issues at play too.
And so, given all these things that we sort of got wrong previously or forgot, are there new behaviors that healthcare providers should think about? What do we need to be learning new for the post-pandemic era?
I think we should all be thinking about preparedness in a way that if this happens again, what might our role be? How might we best triage and care for patients? We saw that happen very early on with rheumatology. There was literature about how best to manage patients who were stable on IV medications. Can we change them to subcutaneous medications? How can we manage from afar? Who needs a telephone visit versus who needs a video visit? I think some of those learnings will be key. I think the pandemic forced us to innovate in ways that we should have done ages ago anyway. I think we saw better accessibility for some of our disabled patients in some cases, and we saw us doing things that disability advocates have been asking us to do forever. And we had just said, it's not possible. Oh, now there's a pandemic. Turns out we have to do it. We're going to make it happen. So I hope some of those lessons continue into the future. Plus, I have to keep coming back to it, but thinking about how we care for a workforce that is then optimally placed to care for patients.
So you are not from a medical family, but your inspiration for going into medical school was your mother, who was an AIDS activist in London in the 1990s, I believe.
Yeah.
And that pandemic dramatically changed medicine in ways that your generation and mine, in fact, may not realize. You know, drug approval and regulatory processes were changed because of AIDS activists, and direct-to-consumer drug marketing in some ways began. You're not a rheumatologist, but we asked you to consider some of the ways that rheumatology contributed to COVID-19, therapeutics and research, and also, you know, some of the ways that COVID-19 may have changed the practice of rheumatology. What are your thoughts on that?
I think really early on, it became apparent that there were considerable learnings coming from rheumatologists and translational immunologists. So for example, we were confounded a little bit at the beginning of the pandemic that there was such heterogeneity in the phenotype of SARS-CoV-2 infection. And it was our rheumatology colleagues that were telling us that this was to do with immune gene pathways, maybe type 1 interferon pathways, HLA haplotypes maybe, so helping us understand that. And then of course, we didn't have antivirals for a while. We've never had broad-acting antivirals. And so in the context of this novel pathogen causing a disease where you have overwhelming immune system activation, severe systemic inflammation, you're thinking about immunomodulatory therapies. And of course, who can pronounce those and understand, timing and dosages and safety profiles, but our rheumatology colleagues. So I think some of those conversations and some of the literature around that was incredibly helpful to begin with. Not to say that as non-rheumatologists can't interpret titers or understand biologics, but there were significant learnings from our colleagues who were just really comfortable in that zone.
And do you see the COVID-19 pandemic changing rheumatology in any specific ways, different from other parts of medicine, or are we sort of along for the ride?
I see it more generally, so I'd love to hear perhaps what you think about this, David, but some of the literature that I've seen about how rheumatology was shifting in the early days in terms of different ways of triaging patients, caring for patients through telemedicine, whether that's video or phone calls, ways of safeguarding healthcare worker well-being in terms of time limits, infection control. I hope we see some of that move forward, at least built into models, so that we are much more prepared for the next pandemic, because there will be another one, but even in ways that just bolster the system for day-to-day operations.
I think that's really a great point, and one that the ACR is working hard on and advocating at the federal level for continued access to telehealth. The other thing that I see is in the area of vaccines, because we've had a global experiment with vaccination with COVID-19, and now all of my patients want to know, what's my spike protein titer? Who has the best spike protein titer and antibody titer? And we're learning about COVID-19 immunization, but we don't know anything really about the other vaccines that we give our patients, whether someone who's getting rituximab or mycophenolate or even methotrexate, what's the best thing to do for their annual flu vaccine or a vaccine against shingles or pneumonia. So I think that's an area of research that really is going to be kickstarted by the interest in the COVID-19 vaccines. Well, Seema, thank you for your time today. We have about 10 minutes for questions from the audience, but before we move into that, are there any last thoughts on the pandemic or the practice of medicine that you want to leave us with?
I think certainly two things that I want us to change moving forward. One is how we tend to the wellness of our providers, how we think about mental health, moral injury, and burnout moving forward, because the pandemic has exacerbated existing issues, and I don't want us to go back to the normal that was before the pandemic when the situation was not good. The other thing that I would love to see from people in positions like yourself, David, is this real concerted effort about the significance of communication for providers, whether that's between us colleagues, but also public facing. I think that has to change. I think we're doing a disservice to the public, but to ourselves as well, if we're not paying careful attention to actually the most frequently used medical procedure. It's not spinal taps, it's not phlebotomy, it's communication. And that needs to be reflected in medical school and postgraduate medical education curricula.
Excellent points. Thank you very much.
Thank you.
Seema, that was fantastic. I just want to say thank you very much for suggesting this novel format for our keynote address. Hopefully the ACR will try it again sometime in the future. And I also want to wish you a very happy Diwali. I know that this is a very special time, and I hope you get to celebrate sometime soon. I want to take the chair's prerogative and ask you a question that I think I've been asked in rheumatology, and it's facing many of our members who are seeing patients with the condition being called long COVID. People with fatigue, cognitive problems, arthralgias and myalgias, and there's a lot of misinformation and maybe myth and doubt out there. How can we communicate better about this condition?
I think the way that we communicate with patients now who have concerns about long COVID might have a significant role to play in terms of the future of long COVID misinformation and disinformation. And I say that having spoken to people, David, already who've said, I went to my doctor, maybe a rheumatologist or another specialist, 3 or 4 months after they said I had recovered from COVID, and I still do not feel well. Like I still can't play with my kids properly. It's hard to climb stairs. They're talking about those myalgias and arthralgias, and they feel dismissed. And it reminds me, when I have been tracing back medical misinformation sometimes to its origins, like where did this piece of misinformation come from? Why are celebrities and just regular people eating their placentas, for example? Often I've been able to trace it back to a dismissal about patients' concerns. In that particular context, dismissing patients' concerns about postpartum depression, for example. And then where do people go if their doctors dismiss them or their doctor hasn't communicated the uncertainty in a way that still gives the patient some reassurance that the doctor believes them? They've gone to people who are peddling all sorts of stuff, cures for postpartum depression, which is eating your placenta, and that just opens people up to such a terrible level of danger. And so I worry now, and I hope we have a lot of emphasis now on how we communicate the unknowns of long COVID, how we communicate the uncertainty in a way that does not disengage our patients from still having a good relationship with their healthcare providers.
Yes, it all begins with empathy. So we have a number of questions, and the top one is, what is the best way to address healthcare worker burnout without just being dismissive and saying, go see the therapist that we've provided for you?
Yeah, I mean, still speaking about therapy though, because again, I've heard stories of residents being told, don't do that, it will be a mark against you. Or if you do go to get psychological care, go far away, go out of the county, for example. I'm glad we're having more conversations about this. I'm sad it took a pandemic to really boost some of our conversations. There were definitely excellent people doing work on this before, but the fact that it's taken such a crisis to kind of really think about how we might address this, I don't have one neat answer, certainly not one that I can say in 2 minutes, but I want to see more discussion about this. And I want to see, in the same way that I talk about a paradigm change in how we teach communications in med school, I think we need a paradigm shift in terms of how we think about healthcare provider wellness. And right now, we have cultures that even make it difficult for our disabled medical students. I've spoken to medical students who say they've been penalized, had terrible things said to them, criticisms, because they're not able to keep up physically with their other medical students. That is the root of this, I think one of the core roots. So we're going to have to see change start early in education. And really, my in a nutshell response to this really important question, David, is we need a culture change. And to do that, that's going to take time, and it's going to take lots of creative ideas. So I'd love to hear more of those from people, maybe on Twitter using the hashtag ACR21. What ideas do you all have in terms of how we can institute cultural change? Because it's a difficult thing to do, but it's a critical thing that we have to do in medicine.
So you just mentioned Twitter and our hashtag for the meeting, and I noticed that your talk got a lot of chat on Twitter. But what do you think about social media as being a messenger of disinformation?
Yeah.
What role does Twitter or Facebook or other social media platforms play in spreading misinformation during the pandemic?
A huge role. These are powerful platforms that have designed algorithms to keep us online for a long time, that have designed algorithms of which we don't have much information, but which we know that for the big social media platforms, these algorithms are incentivized to get us to click, like, and share over and over, to keep our eyeballs on the page at the expense of our well-being, at the expense of mainstreaming fringe ideas like white supremacy. And it's interesting you're asking me this question now, because I am writing a book for young people called What the Fact? And it's all about the information ecosystem. How do you separate the misinformation from the correct information? Because there's very few resources out there for young people. I think we just keep telling them it's terrible, be skeptical, without giving people the tools. And right now I am wrapping up the final chapter, which is about social media. And I thought I knew quite a bit about how these social media platforms incentivize the spread of false information. But the deeper I'm digging, the scarier it gets, even to the point of leaked memos from inside TikTok showing moderators were told, delete videos that represent disabled people. So there's really nefarious things going on, especially with the big platforms that are just cash hungry and trying to keep us online for a long time so that they can make a lot of money off advertising. So we need a massive change there. We need regulation, and we need new platforms to come around, or existing platforms that have different algorithms, because certainly when you map the information ecosystem, as I've been doing, social media platforms didn't create these problems necessarily of false information, but they have massively amplified and worsened this problem.
Yes, part of a big national debate, international debate, I'm certain. So there are a couple more questions I think I'll put together about vaccine hesitancy. And really, I know we talked a great deal about that in our conversation, but people want to know, what are you doing personally or at a public health level to try and combat, vaccine hesitancy? What can we do in our communities? Some concrete things.
Yeah, okay, concrete things. And I'm doing this on the micro level and the macro. Micro, because I have really close friends that refuse to get vaccinated. So even though this is the focus of my scholarly work, which is looking at how false information spreads, I also live with it in a very, day-to-day way. On that micro level, I think opening up platforms for communication, as frustrated as you might be, and you just want to shake people and say, just get vaccinated, making sure that the same way that we try to keep patient-provider channels open so that patients even tell us that they don't want to get vaccinated and they're honest with us, I think keeping those those channels open, realizing these are rarely one and done conversations, realizing that really it's going to take a series of conversations. Therefore, what can I do now to make sure that we continue talking about this and I don't just shut somebody off? And then the macro level, I'll try and be really quick, but we need to make sure that we shift the way that we talk about vaccines. So like I said in the keynote, we're not just focused on printing out lists of ingredients and telling people what's inside the vial is safe, when we understand now, but we neglect to address this in public health and science. We understand that there is so much outside of what's in the vial that informs a person's decision making. And unless we are assessing that, then we're giving this kind of blanket messaging to all of our patients, even though they come to us with really different reasons for having confidence in vaccines or having lots of skepticism about vaccines.
Very wise words, and ones that I think we all have to keep thinking about over and over again to make this work. Well, Seema, I think we could go on for more time than we have allotted today. I want to thank you again for a great keynote address. I think we'll all think about this tonight and how we can take your words to heart and change what we do and help change the minds of our patients who are still concerned about COVID-19. It's been great working with you, and now I'd like to sort of turn it over and we'll have everyone head to our year in review.
Thank you so much.